In this session, we're going to focus on one of the common connective tissue disorders. Connective tissue disorders are part of the autoimmune group of conditions. Now, there are organ-specific autoimmune disorders, and here type 1 diabetes, where antibodies are found directly against the cells in the pancreas, is an example. And then we also find non-organ specific autoimmune disorders. Here, rheumatoid arthritis and systemic lupus erythematosus is a good example. Today we are going to focus on rheumatoid arthritis to gain an understanding of the important aspects to consider in underwriting and claims assessment. Rheumatoid arthritis is part of a group of disorders that are termed autoimmune disorders. Rheumatoid arthritis is a non-organ specific autoimmune disorder, as not only the joints, but other body areas can be affected as well. Rheumatoid arthritis is a chronic, multisystemic, inflammatory disease. Autoantibodies attack the synovium or the lining of the joint space, but the antibodies could also attack other body areas, as we will see in the presentation and complications. Peripheral joints are affected in a symmetrical pattern. The hallmark of the disease is the potential of the joint to cause inflammation, and that leads to cartilage damage, bone erosions, and the typical joint destruction rheumatoid arthritis is known for. The disease cause in rheumatoid arthritis is variable. It can be a mild arthritic disease of brief duration or of a relapse and remitting nature, but also follow a relentless and progressive pathway, affecting many joints with marked functional impairment. Symptoms include a combination of joint tenderness, morning stiffness, and joint swelling. The most common joints that are affected are the hands, feet, wrists, elbows, shoulders, knees, and ankles. The affected joints are usually symmetrical and additive. That means if you have one group of joints, for example, the wrists affected, with every relapse, those joints will be affected again. There are diagnostic criteria to help doctors make the correct diagnosis. The most widely used criteria is from the 2010 American College of Rheumatology and the European League Against Rheumatism. They came together in a big summit and came up with the classification we're going to discuss. Basically, it's defined as synovitis, inflammation in at least one joint, the absence of an alternative diagnosis, and then the achievement of a total score of at least 6 out of a possible 10. So when we look at these 4 domains under which one can score, firstly, it's the number and site of the involved joints, then the blood test or serological markers, and next the elevated acute phase proteins, so another blood test, and then symptom duration. So let's first look at the number and site of involved joints. When 2 to 10 large joints are affected, you qualify for 1 point. Large joints include the shoulder, hips, knees, ankles, and elbows. When 1 to 3 small joints are affected, 2 points are allocated. Now, small joints refer to all the individual joints in the hands. That can be each knuckle, each finger joint, so there are 2 in each finger, as well as the toes. The wrist accounts for 1 small joint. 4 to 10 small joints affected allocates 3 points in the system. If more than 10 joints are affected, you get 5 points, but at least one of those 10 joints must be a small joint. The blood tests that are used is the rheumatoid factor and anticyclic citrullinated peptide, or anti-CCP antibodies. If it's just positive or low positive, you get 2 points. If it's very high or high positive, you are allocated 3 points. Elevated acute phase markers like ESR or CRP allows another 1 point. And then lastly, the symptom duration of at least 6 weeks allocates another 1 point. So if 6 points or more are achieved, you are sure of the diagnosis of rheumatoid arthritis. Let's discuss the laboratory tests done to help to diagnose rheumatoid arthritis in more detail. Firstly, rheumatoid factors, abbreviated as RF. This is an older test with a lot of drawbacks, but it is still used. Firstly, it is found in up to 5% of the normal population. And then only 60 to 80% of people that do have the rheumatoid arthritis will be positive over the course of their disease. And fewer than 40% of patients might only be rheumatoid factor positive early in the diagnosis of rheumatoid arthritis. And that just shows how non-sensitive this test can be. Rheumatoid factor levels also fluctuate with disease activity. It is usually persistent and very high in severe rheumatoid arthritis. And then even if people are in remission, their rheumatoid factor might remain high. A negative rheumatoid factor does not exclude rheumatoid arthritis because up to 20% of people might remain rheumatoid factor negative. A newer blood test, namely anti-CCP antibodies, anticyclic centralinated peptide, is a more reliable test. So anti-CCP antibodies have a similar sensitivity to rheumatoid factor, but has a much higher specificity. So if it is positive, then up to 98% of the time we are sure you have rheumatoid arthritis. As we've mentioned in the criteria, inflammatory markers like ESR and CRP are usually raised to indicate the inflammatory process due to rheumatoid arthritis. Another laboratory test which is often done is the anti-nuclear antibodies or ANA testing. Now this may be positive in rheumatoid arthritis as well, but it is much more specific to SLE, especially if anti-double-stranded DNA is present, and that helps then to make the diagnosis of SLE. Certain factors suggest an aggressive disease course in rheumatoid arthritis. These are explosive onset of disease with multiple joints involved. Higher titers of rheumatoid factor, a positive ANA, the presence of nodules and vasculitis, and failure to respond to first-line drugs. Let's look at some of the examination findings of late or severe rheumatoid arthritis. Hand deformities in the late stage of rheumatoid arthritis is due to the destructive nature of rheumatoid arthritis and the effect of it on the joints. So here in the thumb, we often see hyperextension of the thumb, and that's called a boutonniere deformity. The finger joints are usually skewed away from the thumb, and that's called ulnar deviation, and that's due to the destruction at the metacarpophalangeal joints. Then we find swan neck deformities. These are when the distal interphalangeal joint has a flexion deformity and the proximal interphalangeal joint has an hyperextension deformity. This forms the Z shape of the fingers but actually resembles the neck of a swan, hence the term swan neck deformity. Extra-articular manifestations of rheumatoid arthritis represents the fact that the antibodies do not just attack the joints, but other aspects of our body as well. As a rule, is usually found in people with high rheumatoid factors circulating in their bodies. Commonly, we find skin nodules, and it's a sign of more severe disease. Also, lung involvement, which can range from pleurisy to lung tissue damage. Eye involvement, with dryness, burning and itchiness, and redness of the eye. Vasculitis or inflammation of the small arteries can be found in the skin, nerves, the heart, as well as the brain, of which the latter can resemble a stroke. Cardiac disease with pericarditis, which is inflammation in the lining of the heart, or myocarditis, which is inflammation of the muscle of the heart, and this can lead to congestive heart failure. Felty syndrome is an interesting phenomenon where you have rheumatoid arthritis together with an enlarged spleen as well as neutropenia, which is a low white cell count. Rheumatoid nodules. They are present in up to 20 to 35% of people with rheumatoid arthritis. And they can be found around the elbow, the wrists, the soles, as well as the Achilles tendon, the head and the sacrum. Rheumatoid factor is usually present in these individuals. They can be small, the size of a seed, just underneath the skin in the tendon, or as large as a golf ball. And they occur at any time in the disease course. There is an increased tendency for malignancy, especially the incidence of lymphoma, and this is more so for those with persistent inflammatory disease. The treatment of rheumatoid arthritis. There are 5 major pharmacologic treatment groups. So firstly, simple analgesics. This will be like paracetamol or standard pain medication. And then non-steroidal anti-inflammatory drugs to help reduce the inflammation around the joints. This will be ibuprofen or diclofenac as examples. Thirdly, corticosteroids can be used orally to reduce the inflammation or intra-articular as injections. Fourthly, disease-modifying agents, abbreviated DMARDs, and then lastly, biological agents. DMARDs include medications like methotrexate, hydrochloroquine, and sulfasalazine. DMARDs are defined as drugs that halt the progression of disease, hence the importance to prevent that joint destruction. Methotrexate will in most cases induce a long-term response and is also proven to have a long-term good track record in terms of acceptable toxicity as well as its low cost. People on methotrexate are followed up regularly to monitor their liver and lung functions. Newer biological therapy is now available, so people who are resistant or fail on multiple DMARD treatment can be started on biological agents. In conclusion, treatment is aimed to prevent joint destruction in the long term, so DMARDs should be started early. Patients should see their GP every 3 months and their rheumatologist every 6 months. If DMARDs are not effective, they should be changed or started on a combination of drugs. People should be referred to a rheumatologist early on for specialized treatment. Some patients may require biological treatment. 10 to 15% of patients who do not respond to drug treatment and who develop destructive joint disease should be referred to an orthopedic specialist to consider joint surgery. Thank you. This concludes the section on rheumatoid arthritis.